Ms. Visco?
Thank you. Thank you, Chairman Pallone, members of the subcommittee. I appreciate very much the opportunity to testify today on behalf of the National Breast Cancer Coalition. I'm a 22-year breast cancer survivor. I was diagnosed when I was 39 years old. My son David was 14 months old. I was a partner in a law firm in Philadelphia, and I was fortunate. I became involved with a group of women who launched the National Breast Cancer Coalition, and I soon left my law practice to devote my life to our mission to eradicate breast cancer. We are a coalition of organizations from across the country. Our board of directors is a board of 25 of these organizations representing the diversity that is breast cancer, from the Women of Color Support Group to Nueva Vida, to the Alamo Breast Cancer Coalition, to the California Alliance of Breast Cancer Organizations. Our national grassroots network consists of representatives of many different organizations. We set priorities. We educate our members to understand the language and the concepts of science. We know that women are quite capable of understanding these issues, of accepting the truth, no matter how difficult that may be, and of speaking up for themselves. We critically analyze information. We critically analyze public policies before we set our priorities and before we take positions. And we have but one agenda, and that is to eradicate breast cancer. I know the committee today is focusing on a number of bills specific to breast cancer, and we've submitted analyses of some of those bills to members, and I will submit them for the record. But what I want to focus my remarks on today is our number one priority, and that is the bill that we believe will have the largest impact for all women at risk of and all women who have received a diagnosis of breast cancer, and that is guaranteed access to quality health care for all. We followed our process of research, of critical analysis. We spent several years educating our grassroots, looking at various healthcare systems, reading the literature, researching the system, and we developed our framework, which was submitted with our written testimony to support guarantee access for all, educated patient participation at all levels of the system, shared responsibility and benefits based on evidence. We strongly support comparative effectiveness research because we believe that it is necessary to help ensure quality and affordable health care for all. We need a high level of evidence for doctors and patients to choose which care is appropriate, for whom and under what circumstances. In addition, our framework calls for a significant number, and that's 25%, of educated patient and consumer members on all committees, commissions, and boards involved in health care, including those established to review and assess the best evidence-based treatment options. We commend the committee for its work on H.R. 3200, which achieves many of the benchmarks set forth in our framework, and we were pleased to endorse that bill, and we look forward to working with you to ensure that all individuals have access to the comprehensive quality care they deserve, quality care they need. Everyone should have access, and it must be affordable, not just for the federal budget, but to people. It must be affordable to individuals. We very much appreciate your interest and support of our shared goal to save lives and to end breast cancer. You have the power to make a real difference for all of us, and we know how complicated these issues are, how difficult your task is. We know how complex breast cancer is and how careful we all have to be to make certain that what we are doing is the right thing in terms of women's lives. There are too many unfortunate examples of policy, messaging, and beliefs that have taken hold when there was, in fact, no real evidence behind them, and these actions resulted in harm to women. My written testimony describes them, from bone marrow transplant to breast self-exam to hormone replacement therapy to the misuse of statistics by opponents to health care reform that are looking inappropriately at survival statistics that are outdated from different countries. All of that has been submitted with my written testimony. I know firsthand the horror of breast cancer, and I see that horror over and over again for too many women of all ages, all races, all walks of life. That is why we are so firmly committed to the evidence-based approaches, to our passionate commitment to eradicating breast cancer. I want to take a moment to talk about Carolina Hinestrosa, a strong, passionate, unbelievable activist. She was the executive vice president of the National Breast Cancer Coalition. She founded Nueva Vida, a national support group for women, Hispanic women with breast cancer. She was diagnosed 15 years ago at the age of 35, and then again 6 years ago. She died in June of a soft tissue sarcoma, a result of her treatment for breast cancer. Not breast cancer, her treatment for breast cancer. Just one more story of how complex this disease is, how complicated the issues are. I dedicate my testimony and my work to her memory, and I thank you again.
Mr. Chairman, thank you, and I'll ask all of the panelists, and I thank you for being here. Same question, and start with Dr. Taplin. Some have said that this bill will spread fear of breast cancer among women who shouldn't be concerned at such a young stage of their life. As a physician, I believe that arming patients with medical information is good practice, as long as the message is, of course, well crafted and well delivered. Do you have any concerns that keeping this demographic well informed will cause more harm than good?
Well, I couldn't have said it better than Dr. Sledge did. I think it is very important that messages that we give out are based on evidence, that they're factually correct, and that there's something you can actually do about that information. But I want to make clear that the evidence of harms that some people are concerned about, and we're concerned about certainly with giving messages about breast cancer to millions and millions of healthy women, the vast, vast majority of whom will never get breast cancer, is also the distinct and clear possibility that has been shown in clinical trials of unnecessary biopsies, that young women are going to feel things in their breasts, they're going to have biopsies. Those biopsies can result in infections and in further harm. So it's not just the issue of anxiety. That's why it's so incredibly complex.
And so one of the things I'd like to ask the panel about is why this particular class of women, younger women who do not fit what traditional theories of who is most likely to be diagnosed with breast cancer, why are they more vulnerable than other segments of the population, if they are, and what types of attitudes do they bring to their treatment that make them more challenging as a group, if they are, than other groups of women?
I would say that we don't know very much about breast cancer in any age group. There are some data that younger women are more likely to be diagnosed with triple-negative breast cancer, or a specific type of breast cancer, for which we have treatments for estrogen receptor-positive breast cancer that work well. We have treatments for HER2 overexpressing breast cancer that works well. For triple-negative, we don't yet have targeted therapies that work well. So more research into looking at that type of breast cancer, although there are a number of new possibilities in clinical trials now. There's also the issue of fertility. I was 39 when I was diagnosed. I had chemotherapy. I did go into premature menopause. I didn't have the opportunity to have more children. But there are side effects with treatment no matter how old you are. That is a side effect of treatment for younger women. It is something we need to do more research on. But we just don't have the information. We just don't know enough about breast cancer, and certainly not enough about breast cancer in younger women.